specialized in clinical pharmacology. Clinical pharmacologists are not pharmacologists who love drugs. We love rational application of drugs and using new technologies like translational medicine, which I will speak about. Even the Ministry of Healthcare know about personalized medicine, and they are speaking about prediction, prophylaxis, and they add a few other P's: participative and preventive. But today we're mostly speaking about personalization and different methods that help us approach a patient and giving recipes in a very personalized way. What is personalized medicine? It's a difficult question. The authors had to make a whole review about personalized medicine. They took 600 articles and created some kind of an average term. These authors see that as an approach to improvement of healthcare. So this is a very systemic thing. Knowing biomarkers, knowing individual patients, and individualization of therapy. So these omics we've been talked about, they have to provide those biomarkers. All that has to be interpreted, and there is even an interpretomics. I guess this is a combination of various interpretations. Biomarkers are molecular or genetic that has to work. It does not replace other methods of personalization, and the knowledge of biomarkers helps a doctor select the correct drug for the correct patient if he or she is correctly diagnosed, correct dosage, and of course the correct price of these biomarkers and the correct understanding of why it is necessary at all. This helps find the correct answer, the correct drug, and effective treatment. Why is personalization necessary? Because the efficiency of existing drugs is not enough. Up to 40% with depression do not react to antidepressants. For some oncological drugs, lots of patients do not react, and the evidence-based is very modest, like a 2-week prolongation of life. This is enough to register a drug. We have problems with drug therapy. There are certain clinical cases, like here, epidermal necrolysis, where nevitropine was used. This is warfarin-induced necrosis with a prothrombotic reaction, since CS factors were in deficit and the leg had to be amputated. So side effects are sometimes very adverse. At the same time, our patients are all different. They react to drugs differently, and evidence-based medicine is based on research, which helps us give some average result based on inclusion and exclusion. But the drugs depend on many factors, external and genetic, and those genetic factors can influence up to 50% of response. So pharmacogenetic testing, like translational research before we give a drug, it can predict the effect of a drug and adverse effects as well. So give a tool of personalization to a clinician. There are also old pharmacokinetic, therapeutic, and drug monitoring created in the 60s, which makes it possible to personalize treatment. Pharmacogenetics is a science that works on that. These genetic traits that influence that, and then the basis of that are SNPs, which we can now use to personalize. And in the future, this is pharmacogenomics, which will help us approach this personalization in a more coherent way. There is barely a drug now without biogenetic markers which could influence its safety. 80% of such drugs have genetic information of that sort, and it works in a rather simple way. Instead of average dosages for all patients in different pharmacokinetic diapasons and ranges, some patients can be in the therapeutic range, and some patients with the same dosage are outside the therapeutic range and display certain adverse effects. So pharmacogenetics helps us personalize the choice of drugs so that a drug would work. These candidate genes are those that code products, and they influence the genes of target molecules, influencing the susceptibility. So the detection of these SNPs can predict the response. Such tests, again, personalized tests, they are created with the use of two approaches. This is a gene a candidate, polygenetic analysis. There are drugs, we know how it's metabolized, and we study the SNPs of these genes. I won't be dwelling on that. As for full genomic statin analysis, this is one of the examples regarding pharmacokinetics, and this is the full genomic analysis of statin myopathy. As a result of this research, there was one point was established. Lots of information about pharmacogenetics is available. Does it mean that we have something like that for everything? No, but this information is accumulated on the largest resource, PharmJKB, which is now also an applied resource. There are even guidelines for the use in clinical practice. To implement a test, it's not enough to know information about SNPs. We have to be sure that the SNP is encountered often enough. There must be algorithm of personalization, and this is a weak link of personalized medicine, especially validated algorithms. And we have to remember that such research has to be conducted in evidence-based medicine. There can be various algorithms like the warfarin. The calculation of warfarin dosages is difficult, and there are many calculators, or there are algorithms based on certain SNPs, like the story about clopidogrel and the new drugs. This personalization, is it necessary? It's necessary for people who take problematic drugs, who take highly effective drugs where their evidence base is A or 2A, and problem patients with risk factors and adverse effects. And the guidelines for such drugs of FDA, where FDA writes that there are certain genetic traits that influence their action, but it's just for 20 drugs. There are clear guidelines for the dosage, because the dosage can be based on genetic tests. Otherwise, it's psychiatry, oncology, and to a smaller degree, cardiovascular diseases. There are fewer personalized tests of that kind in recommendations in national guidelines. You can find them in instructions and even in Russian healthcare ministry instructions, but it's not in standards of healthcare, which means that it will not be paid for by insurance companies. When can we make these personalization tests? When there are certain indications like a genetic passport or profile, so as if we see that in the future, to predict and personalize treatment.
Who is going to be subject to such research, such tests? That's the question we need to answer. And who should recommend it? Probably the doctor. It's probably the weakest link. It's the river in Altai. It's very hard to cross it, and there should be some bridge to bring across information. There should be information for the doctor, what exactly he can gain by such research, because the majority of the doctors, unfortunately, they don't know about it. They have some strange abracadabra that they can't interpret. And there should be certain specialist who has all the necessary knowledge and clinic and the tools. For example, our partners from Skolkovo published a document about it, the same name as organizers of our conference, and it says that we should teach specialists in 20 years. There should be specialists in this field, because there should be doctors who who can apply these tests for medical purposes. For example, I have CYP2 C19. What does it mean for me personally? If I have myocardial infarction, what should I say to the doctors who will come for me? Am I going to tell them these figures and explain that you should use different medicine? Probably they will put me into some other institution, not cardiac, but probably a psychiatrist ward. So we actually should bring it into different shape. There should be systematic character. Probably it should be barcoding in the history of the patient, so that the doctor would see on his mobile phone some comprehensive information. Or probably there should be some mobile applications which help to calculate dosage of the drug. Or probably, as in Chicago University, they had the project when they tried to implement those technologies in clinical practice, and the professors tried to impose pharmacogenetics to GPs. And 1,200 patients and 63 GPs participated in it. And those patients had genetic analysis on certain polymorphisms, and which were relevant to effectiveness and safety of drugs, and they tried to understand how GP can use this information. They made electronic system that supported decision making, which knew about each patient what polymorphic features he has, and then the GP could prescribe drugs, but GP didn't have all these horrible things about genotypes, etc. But he has just colors like street lights, red, yellow, and green. It was easier to perceive. If there was red light, then obviously it was not good for this patient, and patient should go to other specialists and take other tests. And because it was 100% when the doctors saw red light, their reaction was in 100% cases they would stop. And in conclusion, to personalize medicine, to make it reality, it's necessary to go stage by stage, and there will be many stages. We should realize it. It's both looking for gene candidates and genetic tests. Also, we should use approach different approaches, though we, of course, have certain arguments about those approaches. Also, there should be algorithms that were proved on big groups of patients, biostatistics, biomathematics, biomodeling. And those algorithms should be clear to the doctor how he chooses his patients, his tests, etc. Also, they should be not just developed by tested. They should be checked on many subjects, and there should be a certain effectiveness economically wise, and also information technologies that should be implemented in clinical practice. I know that Atlas has software that helps to do it. So pharmacogenetics and personalized medicines, it works, and there are proved cases that it works, and there are necessary new algorithms and new research, and probably phenotypic systems should be worked out, etc. And then we'll be closer to what clinical pharmacology founder said. We'll take into account individual traits, individual peculiarities of drug influence on different patients, and then medicine won't be one for all. Thank you for your attention.